Okay, guys, here we are, and we are back still in the 11 o'clock hour. And we're going to talk about endocrine and hematologic emergencies. So, endocrine system and blood emergencies. Two very important things, two things that we deal with pretty often in EMS, right? The endocrine system influences nearly every cell, organ, body function, and their disorders can have many signs and symptoms. Hematologic emergencies are harder for us to assess and harder for us to treat, but we can save lives, right? Stopping bleeding is a huge thing. And we can make an impact in these patients, right? So the endocrine system is a communication system, and that controls functions inside the body. The glands secrete messenger hormones, and these disorders are caused by an internal communication problem, right? So glucose metabolism, our brain needs glucose and oxygen. Those are the two things that keep us running. Insulin is necessary for glucose to enter into the cells, for the cells to use them. And our pancreas produces glucagon and insulin, right? Stores and secretes insulin and glucagon in response to our blood glucose level. So we're talking about homeostasis, constantly maintaining a normal level of blood glucose. Right? Diabetes mellitus impairs the body's ability to use glucose for fuel. Without treatment, blood glucose levels become too high. In severe cases, this can cause life-threatening illness, coma, or death. We're going to talk about that going forward a little bit later. Complications include blindness, cardiovascular disease, kidney failure, loss of limbs, the inability to heal from wounds, and things like that. So what do we need to know, right? Signs and symptoms that blood glucose is high, hyperglycemia, or low, hypoglycemia. Hyper and hypoglycemia can occur with diabetes type 1 and type 2. All hypoglycemic patients require prompt treatment, and that's something that we as EMTs are able to do. So we're going to talk about that in detail. Diabetes type 1, right? It's an autoimmune disorder where the immune system produces antibodies that work against the pancreatic beta cells, right? So we're missing the pancreatic hormone insulin. We're unable to produce insulin. Onset usually happens from early childhood through the fourth decade of life. Oftentimes you hear this one called juvenile onset diabetes. The patient must obtain insulin from an external source. So they have to dose themselves with shots, or maybe they have a unit that is attached to them that is constantly dosing them throughout the day. As technology's advanced, the diabetics have seen an increase, a huge increase in the way that they are able to take care of themselves. So that is good. Many people with type 1 diabetes have an implanted pump, right? So implanted pump technology has gotten better, and it constantly monitors their glucose level, and it provides them with an adjustable level of insulin as their day goes. They can tell it how much they've eaten. They can tell it that they haven't eaten, and it keeps them good to go for the day, right? But these can malfunction, and then we get diabetic emergencies, right? So this happens pretty frequently. So we always need to find out, do they have an insulin pump? Usually we see it hanging on them in a case, or they have it strapped to them one way or the other, or these people will have medic alert bracelets or necklaces or tattoos or something that is going to be obvious. It is going to say, hey, they're a diabetic. These people will also have other people around them who know that they're diabetic. So we'll get a bystander saying he's a diabetic. He's probably having a diabetic emergency. So we need to figure that out. That's part of our assessment. This is the most common metabolic disease in childhood. So some of the symptoms that start: polyuria, peeing frequently. Poly meaning excess, urea meaning urine, excess urine. So these people are peeing a lot. Polydipsia, these people are thirsty increased polythirst, dysphagia. These people want to drink. And polyphagia, these people want to eat. So we call this the 3 Ps: polyuria, polydipsia, polyphagia. And these people are increasingly thirsty, increasingly hungry, and because of the thirst, they are increasingly peeing. When you find a patient with the 3 Ps who have new onset diabetes or high blood sugar, and that you will know very obviously that they are experiencing these symptoms. And it also includes weight loss and fatigue. It happens over a period of time. Oftentimes, in the situations that I found these patients, in my experience, I found them in doctor's offices. They go in with these complaints. The doctor says, "We think you have new onset diabetes." We take them to the hospital because they're just drinking. And when I say excess drinking, I'm talking excess drinking, water by the gallon, peeing off by the gallon, just constantly severe symptoms. Their blood glucose level will be above normal, right? So it'll run high. Say 80 to 120 or 60 to 120, 80 to 120 is ideal. 60 is the low end of normal. They will run high. So over 120, sometimes they'll be 300. Because their kidneys filtration system is so overwhelmed that the glucose is spilling out and into the urine. Glucose becomes unavailable to cells, and their body starts to burn fat. So that's where they start to lose waste. They produce acid as waste, and they smell of ketones. So these people will smell fruity. Sometimes they'll smell drunk, like intoxicated or alcohol smell, and that's ketones. So their kidney can't maintain the acid-base balance, and they become acidotic, right? Too much carbon in the blood, and they try to breathe it out, right? So they'll be breathing fast. We call that Kussmaul's respiration. So it'll be, I hope I'm not blowing in the microphone, but it'll be very exaggerated. It'll be a forceful exhalation. They are just trying to blow it off. They are peeing off their fluid. These people will appear acutely ill. If fat metabolism and ketone production continue, they can not compensate by peeing it off, breathing it off, and they will proceed into diabetic ketoacidosis. So this is when their blood sugar gets just so high, they are unable to keep it low with those natural body reactions, and they just become super sick. It can appear as a generalized illness, fatigue, weakness. They are no longer compensating with those mechanisms. They are now decompensated into diabetic ketoacidosis. This can lead to death. Typically, their blood sugars will be high. They'll be over 400. Usually our blood glucose meters, like this one that I have here, will read to about 500. After 500, it'll say high. Some blood glucose meters you might run into, like the ones that we have in the hospital, will read up to 600, maybe 700. I'm not entirely sure off the top of my head. But these patients will have sugars that can approach 1,000 milligrams per deciliter. That's incredibly high. These people are incredibly sick. I think the highest blood sugar that I've personally ever seen was 1,200 in a live person, and those people are acutely ill. So what causes the diabetes type 2? Now we're talking about type 2. This is a resistance to the effects of insulin at the cellular level, right? So there's an association between obesity and increased resistance to the effects of insulin. The pancreas produces more insulin to make up for the increased levels of blood glucose and the resulting dysfunction of cellular insulin receptors, right? So insulin resistance can sometimes be improved by exercise and dietary modification. I can attest to this one personally. For those of you guys who know me, I was pushing the type 2 diabetes due to obesity. And after I had surgery, I my type 2 diabetes went away completely. My body's ability to use the insulin effectively increased exponentially, and my A1C, my blood glucose level, went right back down to normal. So a year later, I've got no sign of diabetes, and that's good. So staying healthy and eating well is imperative, right, to prevent this type of diabetes from harming us, right? So we still make insulin. We just can't use it as effectively because of things like obesity, right? So oral medications are usually used to treat type 2 diabetes. These people have the insulin. They don't need it. They need to take these pills to allow them to use the insulin better, right? There's some increased secretion of insulin, and it does pose a risk for hypoglycemic reaction. So we might see hypoglycemia more in these patients. Some medications decrease the effects of glucagon and increase the release of glucose stored into the liver. And in those situations, we see higher blood glucose. We don't need to know that. We're not going to be trying to calculate what type of diabetes it is on a call. Really what we want to know, right, is their sugar high? Is it low? Is it normal? And what type of diabetes do they have? Do they take insulin or do they take pills? Or maybe they don't take anything at all. Injectable medications and insulin are also used for severe types of type 2 diabetes. So, type 2 diabetes is often diagnosed at a yearly examination. That's how they told me I had diabetes. And it's usually related to high blood glucose levels. So you might hear the term A1C. That is the relative monitoring of your blood sugar over time in your blood levels. And they look at that in your yearly exam. So you go for your yearly exam, they notice that your A1C was here last year, and now it's here, and it's higher than it should be. They'll say you have type 2 diabetes, right? And these people usually have some sort of complaints. They've got infections. They're not healing properly. They have a change in their vision. They've got numbness in their feet or maybe their hands. And those are symptoms of diabetes. Another phone message. So, symptomatic hyperglycemia. Let's talk about that. High blood sugar occurs when the blood glucose levels are too high. So the patient is in a state of altered mental status. This results from several combined problems. Type 1 diabetes leads to ketoacidosis with dehydration from excessive urination. We talked about that. In type 2 diabetes, this leads to a non-ketotic hyperosmolar state of dehydration. Again, non-ketotic, meaning they're not spilling off ketones. They're not acidotic. So this hyperosmolar, hyperglycemic, non-ketotic syndrome, we used to call it HHNK, now it's HHNS. Previously, you may have heard hyperosmolar, hyperglycemic, non-ketotic diabetic coma. They've changed the wording because not all patients are in comas. They have a non-ketotic syndrome. When blood glucose levels aren't controlled in diabetes type 2, they get these key signs and symptoms. Higher glucose levels in the blood cause the excretion of glucose into the urine. So they get increased fluid intake. They can't drink enough fluid to keep up with the blood sugar levels. Their urine becomes dark and concentrated, and they become unconscious or have seizure activity due to severe dehydration. So these people are sick. Don't mistake that. They are very sick. This is an acute emergency, right? Symptomatic hypoglycemia. So we're going to talk about that. Symptomatic hypoglycemia is when their blood sugar drops below a level that's going to keep them up. So we said below 60 is an indication for treatment. If we look at the state protocols want us to treat diabetic patients that have a blood sugar below 60. And it varies from person to person. I've seen people with a blood sugar of 60 that have an altered mental status. I've seen a blood sugar of 10 that didn't. So it depends on human tolerance. So we treat the symptomatic patient, right? So that's where I wanted to make sure we say symptomatic is the key word, right? This can occur in patients who inject insulin or use oral meds. When their blood levels remain high, their glucose is taken out of the blood rapidly. If it falls, then it has an insufficient amount to supply the brain, and they get a decrease in mental status. They become aggressive, they display unusual behavior, they become unconscious, they get permanent brain damage if they're not breathing effectively. The hypoglycemia will develop quicker than hyperglycemia. So the blood sugar will drop much faster than it will go up. So what are some signs and symptoms of hypoglycemia? Altered mental status, confusion, sweaty skin. These patients will be soaking wet, absolutely sopping wet in sweat, to the point where you might think, hey, somebody dumped a bucket of water on this guy. No, he's just soaking wet from his low blood sugar. And they will have snoring respirations because they are unconscious. They're having a difficult time managing their airway. So we give them oxygen. We position them. We open their airway. Usually just opening their airway and positioning them is enough to make it better. A little bit of oxygen, and then we check their blood sugar. How do we do that? We do it with a blood glucose meter. Some of you guys may have seen these. Some of you may know how they work. But simply, we use a test strip. The test strip goes into the glucometer, and we get a sample of blood with a finger stick and put it onto the strip. And that gives us a reading. So symptomatically below 60, we're going to treat these patients. How do we do that? Well, as EMTs, we treat them with something called oral glucose. Oral glucose. And we're going to talk about the treatment with oral glucose in a minute. So hypoglycemia is quickly reversed by giving the patient glucose. And you see here, the blood sugar at the bottom of this graph is 40. They're in a hypoglycemic crisis. Below 80, they're considered to be a hypoglycemic state, but they're usually alert and oriented. They're usually able to answer our questions. And above 120 to about 400, they're in hyperglycemia. And above that, they're either in DKA or HHNS. They're in some sort of symptomatic hyperglycemic state, right? So what do? We do the same things. Scene size up, right? Patients with diabetes can be using syringes or meds, so be alert for these clues. We put our little detective hat on. We're going to figure out what's going on. Use our standard precautions. Ask the bystanders. Usually, people are going to be very forthcoming with this information. Figure out, is this a mechanism of injury or a nature of illness? Usually it's a nature of illness, but sometimes it could be a mechanism of injury because when they lost consciousness, they struck their head, they fell, they rolled off their bed, something like that. General impression and airway is important, right? If their blood oxygen level is below 94, we need to give them oxygen to bring it back up, position the airway. We may have to do that on these patients, right? Watch out for Kussmaul's respirations. They may have snoring respirations. Again, open the airway, manage their breathing before we move on. These people can have either warm, dry skin or pale, moist skin. Hypoglycemic patients, you're going to see this very prominent, wet skin. And then make a transport decision. With a lot of these patients, if their blood sugar is high, we're going to transport. If their blood sugar is low, we can treat them on scene, and oftentimes these people do not want to go to the hospital. So we are going to treat them and we're going to leave them on scene. So investigating the chief complaint, this is important. Figuring out what has led up to this. What does this patient's diabetic life look like leading up to this moment? Have they eaten? Have they drank? Have they been eating and drinking too much, too little? Have they been taking their medicine? When did they take it normally? Have they told you, I've not felt well? They usually keep a log. If they don't keep a log, you can go into their blood glucose meter and you can look back through the history of their results to find out how their blood sugars have been. And usually that's a really good telltale that they've been running high, they've been running low. Or you'll find things around them like chocolate, candy, things that say, hey, this person might be having a blood sugar issue. So ask our sample questions, and we can add some qualifying questions. Do they take insulin? Do they have an insulin pump? Do they take a higher than normal dose? Sometimes they will take a higher than normal dose because they know their blood sugar's been running high. And then our physical assessment, right? When we suspect there's a diabetic related problem, focus on their mental status, focus on their airway and protecting that, right? And get a GCS. It's going to be lower when they're unconscious than it will be if they're conscious, awake, and talking to us. And then compare. So once we wake them up, is their mental status normal? Ask the bystander. Is this how he would normally respond? Is this how she would normally respond? So use our glucometer, use our pulse oximeter, and we're going to monitor for these things, right? Hypoglycemia, respirations are going to be normal to rapid. Their pulse will be weak and rapid. Their skin is going to typically be pale, clammy, and they'll have a lower blood pressure. Hyperglycemia, their respirations will be deep and rapid. Their pulse might be rapid, weak and thready, and their skin might be warm and dry with a normal blood pressure. So our portable glucometer, right? Know how it works. We're going to go over that in detail. Know the upper or lower ranges. So a meter like this will probably bottom out around 10 and say low. And on the high side, it will be around 400 or 500. Normal non-fasting adult and child blood glucose levels range from 80 to 120. Neonates, that should be above 70. So what do we do? Hypoglycemic conscious patients, encourage them to take tablets or drink juice. We can administer them this. If they're awake and they're able to talk, we can give them the glucose gel, right? So this here is a tube of glucose gel. This is a 25-gram dose. It is essentially cake icing. We put it in the mouth, let them absorb it, let them swallow it. This is a slow route of administration. So once we give it, it's going to take time for the blood sugar to come up. Same thing with the chewable pills, same thing with the orange juice. The paramedics have the ability to give sugar directly into the bloodstream, and that is almost instant. These people will wake up. Sometimes they get combative. Sometimes they get violent. So be cautious. Remember, keep our heads on a swivel. Always be aware of our surroundings and the things in the room, weapons, things that could be used as weapons. And then if we need to, prepare for transport, right? So the possibility exists that we may have to. If we get in doubt, if we don't know what we're doing and we don't have ALS available and we need to call ALS, or we can contact medical command. So we know what medical control is. We know that that's an available tool to us to consult with them to find out what they want us to do. And then reassessment, right? Always recheck a blood sugar after we give the medication. We give the medication, we wait 5 minutes, we give another blood sugar. And then another 5 minutes, we do it again. And we see, is it trending up? Is it trending down? And that kind of gives us an idea, is our treatment effective or not? And then this is just some information on our oral glucose. The 15 on these, I believe, is 15 grams. These are 25-gram vials here that we have in the classroom. So, right, contraindications. When are we not going to administer the oral glucose? We're not going to administer the oral glucose if the patient cannot swallow or they're unconscious. Remember, always put your gloves on before we put anything into the patient's mouth, and don't stick your fingers in there because they might bite. Follow our local protocols. And when we get back into class, we'll talk about our protocols. Frequently reassess, transport if we need to. So what's the presentation of hypoglycemia look like? Seizures can be a serious sign and symptom of hypoglycemia. So we need to be aware that the seizures can happen, and we need to be prepared to see them and manage the patient throughout that. And that's just keeping them safe from themselves and allowing the seizure to go its course. Altered mental status can be caused by other conditions, right? So we need to get a very good assessment to figure out why these patients might have an altered mental status. Hypoglycemia can be a misdiagnosis of a neurologic dysfunction, right? So intoxication, sometimes diabetic patients have the police called on them. Look for an identifying bracelet, right? Excuse me. Perform the glucose test at the scene. Diabetes and alcoholism can coexist in a patient, right? So the same with drug use. So we can see all of these things and they all present very similarly. So we need to use our assessment and our history taking to find out what's going on. So these patients may not have a gag reflex. They may have vomit or other stuff in their airway that we need to clear out manually. So we need to monitor the airway. I can't stress that one enough. We need to monitor these airways. So let's talk about hematology, right? This is a study of blood-related diseases. And there's 3 disorders that we're going to talk about: sickle cell, hemophilia A, and thrombophilia. All right, so blood is made up of 4 components: red blood cells, white blood cells, platelets, and plasma. In sickle cell disease, this is an inherited disorder. Predominantly affects African Americans, Caribbean, South American ancestry. People with sickle cell disease have a misshapen red blood cell, right? It's shaped like a sickle. And this can cause clotting or blockages in the vasculature. This causes hypoxia, pain, or organ damage. Usually, if people are having a sickle cell crisis, they know, right? So some complications include anemia, gallstones, jaundice, splenic dysfunction, and vascular occlusion with ischemia. So here's a picture of what this sickle-shaped cell looks like. Some are normal, some are sickle-shaped, but it causes very painful and sometimes life-threatening conditions. So clotting disorders, hemophilia. This is rare. There's only about 20,000 Americans that have this disorder, and hemophilia A affects mostly males. Decreased ability to clot after an injury, and it could be life-threatening. Patients typically have intravenous factor replacement infusions with them to help prevent the blood clot, or to help the blood clot. I apologize. So another clotting disorder would be thrombophilia. This is the body's inability to maintain the smooth blood flow through the venous and arterial systems. There's a concentration of particular elements in the blood that creates clogging and blockage issues. The general term for many conditions that result in blood clotting more easily than normal, right? Some things like deep vein thrombosis. This is a very common problem. We see this in sedentary patients, patients who are bedbound, hospital patients, elderly patients, and we have some processes to avoid or prevent blood clots: blood thinning medications, compression stockings, and mechanical devices. So there are lots of risk factors. The treatment is anticoagulation therapy. So these patients will get blood thinners. And they're oral medications, and they're usually given at least 3 months after diagnosis of a DVT. The clot from a DVT can travel throughout the body into the lungs, into the brain, or into the heart and cause severe symptoms: shortness of breath, stroke, or death. So again, the scene safety stuff, guys, this is the same story. We're always approaching the scene safe. And we're always figuring out mechanism of injury and nature of illness. Do we need cervical spine immobilization? Probably not. If there's a trauma emergency related to these, then we'll take the trauma precautions. But get a general impression, monitor the airway. In a DVT, if the clot has moved into the lungs or the heart or the brain, let's provide airway support for these patients. Sickle cell patients will have an increased heart rate. Hemophilia patients are at high risk for blood loss. Make a transport decision. Investigate their chief complaint. Same thing with all of our medical assessments. This doesn't really change, right? We ask about the pain. Is it isolated? Is it local? Where is it? Is it throughout the entire body? Do they have any visual disturbances, nausea, vomiting, altered mental status, shortness of breath, chest pain? Our sample history is focused on their symptomology. These people will tell us they've had a crisis before. They have their clotting medication with them. In those cases, contact medical command for advice on what to do. And contact medical command pretty quickly because they'll give us a good idea of what we should or shouldn't do in these cases. Our secondary assessment, focus on the joints. Our vital signs should be complete, right? Pulse ox, if we have that, blood sugar, if there's altered mental status, things like that. This is a common recurring theme. And then our reassessment. Always reassess. Every 5 minutes for the unstable, every 15 minutes for the stable patients. Sometimes these patients will be stable and they just need transport to the hospital. So what are we doing, right? Mainly supportive care. And then we're going to manage the symptoms of the symptomatic patients. And that could be high flow oxygen, position of comfort, and rapid transport off to the hospital. If you guys have any questions, shoot us a text message, let us know, and we hope to meet you up on Thursday. If you're following along in Schoology, I think the next almost 75 slides is review. So go ahead and review, follow along in your book, and let me know if you have any questions. All right, guys. Thanks a lot for watching. Have a great